morning. My name is Kozek. I'm honored to be here in this group of orthopedic surgeons, orthopedic colleagues. I'm an anesthesiologist and intensive care physician working in a more or less private hospital here in Vienna, dedicated and specialized in orthopedic surgery. So this is my affiliation and my context in terms of orthopedics. This is my declaration of potential conflicts of interest. I work together with a lot of companies in the field of hemostasis. I use them as distributors of know-how and training and education. Here I'm now only in an academic mission in order to discuss with you things when it comes to bleeding during major orthopedic surgery, when it comes to thrombosis postoperatively. So what I wanted to do is to spend the next 45 minutes to talk about physiology, to reconsider physiology with you together, to derive a pathophysiology-driven, oriented therapeutic approach, and then to touch down on patient blood management, which is important in orthopedic surgery specifically, and highlight European guidelines in this area. Honestly, I should have started about 1 hour early and I should have finished, and my conflict of time is that I should be back in the OR earlier than expected. So I will probably rush through all these slides, and I do ask you for your understanding. You will get all the information as a USB memory stick anyhow, and you will see my email address later on. So in case we cannot discuss all issues today in this room, there will be plenty of opportunities. Hemostasis. It's all about balancing. Balancing between the protection from uncontrolled blood loss and protection from uncontrolled clotting. And this is what we probably have learned in the past, which is Spanish or Chinese, or at least not understandable. It has changed, our understanding has changed, and what we think is important to reconsider when putting your scalpel, your knife into the body of your victim, of your patient, is that it's all about networking. Balancing now the information from various blood cells, blood plasma, and blood vessels, because the vessels you cut with your knife is not an innocent bystander, but rather a structure that can hopefully contract and interact with the other players in that networking processes. So if we want to reconsider what goes on when there is trauma, when there is surgery, then, of course, there is the cut of a vessel. And the subendothelium is the structure that triggers the kick-off event. One of the first things to occur in terms of primary hemostasis is that the platelets, now symbolized as a disc here, a gray disc, stick to that lesion, to that site. And there are various receptors that are responsible, and there are various molecules who function as a link to the vessel and the subendothelium. In this case, von Willebrand factor and glycoprotein 1b receptor on the resting platelet surface. Von Willebrand factor is like a super glue in the hemostatic system. It is a big molecule which triggers that link, and which is really important whenever it comes to surgery or trauma, because also in high shear stress areas it works fine. It attracts, it binds platelets to the lesion. And there is another important molecule that helps us stop bleeding in our patients, that is collagen. Collagen is not only a mediator of this adhesion process, binding the still resting discrete platelets to the area of interest, but also to activate these platelets. And they are transformed to activated platelets by collagen and also thrombin that is about to being built during the plasmatic coagulation system. The shape change means that these round sleeping platelets transform into very high reactive particles, and this is my scheme for symbolizing how this functions. They get such pseudopodia, and active negatively charged phospholipids are there on the outer surface, and this is the important thing when it comes to formation of a clot, because on the surface of these shape-changed activated platelets, all the further processes occur. Secretion is another function of the activated platelets. They externalize and release their granular content, and they aggregate. And the mediator for this aggregation, the binding of activated platelets among each other, is fibrinogen. So we need, for various aspects in orthopedic surgery, in anesthesiology, we need fibrinogen on board of the patient. Why? Because it is the main ligand between the activated platelets forming the platelet clot, and it is the main factor when it comes to a clot. Clot stability is determined by fibrinogen. And the receptors responsible for aggregate formation is another glycoprotein, so-called 2B3A receptor. What we learned and what our evolution was from the Chinese symbol of the coagulation cascade to our current understanding is that there is the cell-based model of hemostasis. All happens on the surface of the activated platelets via the interaction with calcium in a good milieu with an adequate pH and adequate temperature. Enzymes like to interact with substrates like fibrinogen, and with their cofactors they are really good in interacting with their substrates. And we learned that this cell-based model of hemostasis is really what occurs in vivo, and we know that for at least now 16 years. And it is not only the extrinsic, intrinsic pathway and the common pathway of coagulation, of plasmatic coagulation, but rather the initiation, amplification, and propagation phase. Initiation is all these processes that are meant to produce a little bit of thrombin, which is then further amplified, and finally in a thrombin burst in the propagation phase, there's so much thrombin here which is able to transform fibrinogen into fibrin, which is required to form the clot, which is required to stop the bleeding upon your knife. There are various schemes, and all the lecturers like to present their own schemes. The message is always the same. There are various phases that can be artificially derived and artificially defined, but the important message is we need platelets. We need activated platelets with their pseudopodia in order to have a good function of all these enzymes and coagulation factors here, in order to produce enough thrombin, and finally in the stabilization phase is insoluble fibrin. To go through this cascade now quickly, in the initiation at this site of injury I mentioned before, where the platelets are still in the discrete resting form, tissue factor is like the firing key. A patient without tissue factor would bleed to death, but tissue factor is exposed on many, many cells and is there in order to form a complex with 7A. And together, this is a very potent combination to form 10A. 10A is like the neuralgic point in the coagulation system. A little bit of 2A, which is thrombin, is produced. There's an amplification, which means that there is more thrombin about to be generated via this complex here, consistent of 9A together with 8A. This is a helper of 9A. And together, these two pathways finally lead to a lot of 10A formation, and together with his helper 5A, the thrombin burst occurs. It is important that the system knows that thrombin must stick here to the site of lesion. If thrombin would be disseminated throughout the whole body, we would have a problem, because then there would be disseminated intravascular coagulation. So the important thing is that all these processes occur here on the surface of the activated platelets, which are bound to the site of injury, which guarantee that this process, this very potent process, is really only occurring here. Yeah, and the end product is fibrin. And fibrin, after being transformed out of fibrinogen via thrombin, is first a molecule that is not so strong. But if fibrin, two pieces of fibrin stick together and form a fibrin dimer, or if they are cross-linked finally by factor 13A, then it gets a polymer, and this is the strong structure. This is what we need. So patients without factor 13 also have a problem in forming a strong clot. What we need in our patients in order to be cooperative in terms of forming a clot after incision is that they have enough surface of platelets, that they have fibrinogen, and that they have factor 13. There is a stabilization phase, and for wound healing, which is the ultimate goal and the ultimate reason for all these coagulation processes, because it activates fibronectin, collagen, and other things that finally trigger wound healing. And I think you all need wound healing in order to have a good result of your interventions, surgical interventions. When you have the opportunity to talk about physiology of hemostasis, then of course fibrinolysis is one of the aspects that need to be mentioned as well. It is not only forming a clot and the story is over, but it is also to dissolve the clot again, because otherwise the bloodstream would be closed forever, for the whole life. So we need processes to dissolve the clot that initially stopped bleeding. And here we have plasmin, which is so important for us, for our patients, to crack down this fibrin network, to crack down the fibrin net into soluble fibrinopeptides and so forth. And there are various interactions of antifibrinolytic activity via plasminogen activator inhibitor, activated protein C, TAFI, antiplasmin, and so forth. A very complex cascade, still from Mother Nature, to be prepared and designed in order to keep that process localized to the site of injury and not to have lysis all over the body, systemic lysis. This is not what is helpful for the patient. So if you still go back to that old-fashioned scheme from the 1950s and 1960s with the intrinsic and extrinsic and common pathway here, you can see that various endogenous processes finally lead to anticoagulation. Fibrinopeptides, for example, produced during fibrinolysis inhibit thrombin, and therefore this feedback loop is stopped, or leads to a stop of further thrombin and fibrin generation. Activated protein C, protein S are produced by thrombin and block these compounds here. Pi is blocked as well, and macroglobulin and antitrypsin block thrombin. So there are many, many cascades. I don't want to bore you, but still remember, when putting an incision into your patients, all these processes silently take place and help you and help the patient to stop bleeding and to keep that coagulation processes sticked to the site of your surgical intervention. Antithrombin, TFPA, further players in that cascade. Platelets do not only have a procoagulant activity, meaning that on their surface these processes take place. They also have various reactivity aspects in terms of secretion and in terms of aggregation. And aggregation upon various agonists can be measured and assessed in the lab and allow us to detect various inherited disorders, rare, but if present in your patient, really dangerous because they can bleed extremely. So it is important to have a measure of platelet function ahead of surgery, of orthopedic surgery. How should we do that? I mean, to assess glycoprotein 2B3A is not so easy in clinical practice, daily clinical practice. There is a very easy and very cheap way, which is to assess the standardized bleeding history. Because patients with pathologies here in the platelet functionality typically have mucosal bleeding events and bleeding symptoms. So even without the PFA 100, without flow cytometry to look inside the platelets or in their receptor expression, you can indeed assess their functionality just by asking the patient, do you have epistaxis regularly without hypertensive phases, without seasonal peaks due to polynosis? Do you have hypermenorrhagia? Typical mucosal bleeding, typical for platelet dysfunctions, and von Willebrand patients can hardly be overseen if their pathology is severe by doing a careful standardized bleeding history. POB is the abbreviation for perioperative bleeding. POB is something which we all know from daily work. Sometimes it's more, sometimes it's less, but if it goes beyond 20% of the patient's blood volume, meaning about 800 milliliters, then we arbitrarily call it severe. This is severe bleeding. And this means that there is an emergency situation. This is not normal that so much blood is lost. And it may be, of course, a risk factor for various unwanted issues, such as anemia, transfusions, and it may increase morbidity and mortality. And of course, it increases our efforts, our energy spent, and hospital costs. So it is worthwhile to consider modalities to reduce bleeding and to avoid all these things. The lethal trial. Anemia, bleedings, and transfusion. Blood transfusion is not something that is harmless. And in that concept of patient blood management, in all these trials behind, we learned that allergenic blood from another donor given to the bleeding patient, has its hazard. I'm not talking about hepatitis transfer or infections like HIV. I'm talking about an immune modulation, transfusion-related immune modulation, which is the most likely cause for an increase in morbidity and mortality, not immediately during or after transfusion, but within the next years. We have good registry data, good controlled trials showing us that there is a dose response, meaning that there is more than just an association. So to avoid anemia, to stop bleeding, is a preventive measure to avoid transfusions. Big Five. You can go for the Big Five in Africa, but you can also use it as a symbol. What Big Five things do you need to stop bleeding? Of course, considering now pathophysiology or physiology, you need coagulation factors, for example, for the amplification phase. You need a matrix, platelet surface, and the subendothelium, for example. You need fibrinogen. You need the substrate. You need a good milieu where all the enzymes and factors want to function. Hypothermic conditions in traumatology are a problem. If you cannot keep hemostatic enzymes happy, they will not function. There are enzymes like all the other enzymes too. And you need the contribution of the vessels. So what are now the big 5 causes for bleeding, for POB? A decreased clot stability and quality and formation. If it takes too long to form a clot, decreases in primary hemostatic capacity, platelet function, and others. You know what the others mean? Coagulation factor 14, for example. This is surgical skill. If you want to have another scheme, you are not laughing. This is typical because you are coagulation factor 14. Platelets and vessels are triggered first when it comes to a trauma. Then thrombin is generated via these processes. And then the clot forms. And clot quality, the strength here, is defined by these players here. And then the fourth important aspect is lysis. It must be dissolved in the end. And the problems, the causes for POB can be hypocoagulability, if this clot is not strong enough to withhold the bloodstream and blood is still running out. If the clot is dissolved too fast, hyperfibrinolysis, a typical problem after having a tourniquet, for example, for knee, total knee repair, and after opening the tourniquet, mediators triggering hyperfibrinolysis are swept into the systemic circulation. Hypoactivation means that it takes too long to get to that point of thrombin burst, and platelet dysfunction is another issue. So the problem we have is that, yes, for tourniquet opening we know already what is going to happen, and in most hospitals, I guess also in your hospitals, you give prophylactically tranexamic acid or any antifibrinolytic drug systemically, IV, or intra-articularly. This is our understanding, and therefore in a prophylactic pattern we do this already. But all these other things, specifically in trauma surgery, can occur without any predictive pattern. And these multifactorial pathomechanisms, hypocoagulability, hypoactivation, platelet dysfunction, and so forth, may evolve in a dynamic, unpredictable pattern, and they are dependent on the intervention, and they are dependent on the patient's risk factors. For some interventions, now not in the field of orthopedic surgery, for example in postpartum bleeding, we know that again it is a model for hyperfibrinolysis and it is a model for defibrillation. So the intervention does also its effects. And the pathomechanisms finally are complex, and it is different to treat hyperfibrinolysis or dilutional coagulopathy, or the triad of malfunction, or the effect of pre-existing anticoagulants or antiplatelet drugs in this bloody visual cycle. So you need to identify what's going on. And if you do not measure it or assess it in the bleeding history, you cannot manage it. This is the pathophysiology-driven approach to bleeding management. So the big 5 therapeutic goals is, of course, to give the right stuff at the right time and fast. At the right dose, not a little bit, but in a good, adequate dose to the right bleeding patient. Some things may help us to keep our lives easier on the front row, in the front row when treating severely bleeding or massively bleeding patients. And one of these helpers is the TIC app. It is only available in the iTunes store, not in the Android store. Our other apps are available also in the Android store, but this is only programmed for iTunes. And it is not only showing an algorithm how to treat trauma-induced coagulopathy, for example, but it also has a simulation area where you can add the weight of your simulated patient, the injury severity score, and the results of a test that is indicative for fibrinogen function, for example, and then the system allows you to assess the doses. So it's a dose calculator. And there is definitely pathophysiological understanding inside. So you are warmly invited to use it. In some countries it doesn't work because it is limited, for example, to European areas and not to US. And managing orthopedic-related bleedings is a topic, and is also mentioned, of course, in our European Society of Anesthesiologists' work and the guideline. And this has very recently been updated and republished. And there is, of course, also pathophysiology and applied understanding inside. Patient blood management is a bundle concept, and it is not focused on the allergenic blood product, the RBC, but it is focused on the patient's outcome. And this is why in the center here it says improved patient outcome. And there are various things we can very good really live and implement in orthopedic surgery. For example, dear colleagues, optimizing hemostasis is what means pathophysiology-oriented approach. Management of anemia is something which I warmly recommend to you. In total arthroplasty, you're warmly required to think about optimizing anemia in these elective cases before you go with that patient in the OR. And if your anesthesiologist says, hey guy, there is a problem, the hemoglobin level is below 13 or below 12, and we do an elective case, please let us detect the reason for anemia first and correct it so that your patient will go to the surgical procedure with an adequate normal hemoglobin level instead of a lower one. And if this occurs, then please reconsider this request and do what is really internationally recommended to do and implement patient blood management. Why? Because you can avoid allergenic blood transfusions later. Rehabilitation of your patient is better because the reserve in endogenous oxygen carriers is higher. So it makes sense, and it is a win-win-win situation also for the hospital and also for the society when it comes to costs again. This means patient blood management is also pathophysiology oriented. And sometimes you hear that PBM, patient blood management, has 3 pillars. And the 3 pillars are here for optimizing erythropoiesis, for minimizing blood loss, and the management of anemia. And it is divided here in this scheme in a 9-area scheme into pre, intra, and post-operative strategies. And for example, what I mentioned earlier, optimization of erythropoiesis pre-operative means algorithms how to assess anemia, make a differential diagnosis, and in most cases it's very easy, the answer. The answer is give iron. This is the most likely case of anemia. It is a well-functioning process and concept, and because it is so good, and I didn't bring the studies here showing you, proving to you that it really works. You can reduce morbidity, and you can reduce transfusion, and you can reduce mortality in your patients at time points that are after hospital discharge. And this is a tricky thing because we as anesthesiology just usually see a patient from the pre-op clinic to our ICUs. But usually we don't follow their track later on. You probably see your patients much later, earlier, before it comes to the indication for surgery, and much later because they come hopefully back to your clinic, to your area, to show how everything is functioning after surgery. So you have a broader view on the patient's outcome, but probably your view is not broad enough to see what's going on 90 days or 10 years after surgery. So therefore we need reminders also from the World Health Organization, which have the data from long-lasting registries showing us that PBN should be implemented in all member states, also in your state, in your area. There is a resolution showing us that the long-term hazards of transfusion need to be acknowledged. So it is not an answer if there is severe bleeding just to give blood. This is not an adequate answer in our times. In Austria, we have a quality standard, patient blood management, launched by the Ministry of Health. So top down from the highest legal structures, we have the clear signal: do what is logically in terms of pathophysiology, do what is required in terms of patient blood management and PUB management as outlined before. This is of course not prepared by the lawyers and by all these guys in the Ministry of Health, but behind these guidelines and requirements there is a medical information from 10 societies, including trauma surgery, including orthopedic surgery and orthopedics, and we all agreed upon our interdisciplinary recommendation for the management of anemia perioperatively. So there are all the guys involved and responsible for the patient care had their voice in this quality standard. It works. Reducing infections, you just had a long lecture on infections, and sometimes probably it is not a problem with the germs per se, but probably it is immunomodulation you triggered just by transfusing the patient. So there are various interventions that finally may aggravate probably this issue of infections in bone surgery. So what all these recommendations tell us is, whether it be the World Health Organization or the ESA management guideline or the national quality standard, is be prepared. Take a structured patient interview. This is much better than doing these old tests from the 1950s with PT, INR and things like that. This is an example of a structured interview we use here in Austria, prepared by our Austrian Society of Anesthesiology, and we have various questions here, of course, in German, because most of our patients understand German, and they are written in a way that patients can answer this interview. So we ask about symptoms of bleeding, which are typical for bleeding disorders, and we ask about anticoagulants. Be prepared. Not only a structured assessment of the hemostatic side is important, but also in assessment of potential signs of anemia. So whenever you do not arthroscopy, but big joint replacements, big scoliosis surgery, big stabilization of the spine, in these big surgical interventions with a relevant risk to end up in severe bleedings, meaning more than 800 milliliters, there you are advised to take a blood count before surgery. And if hemoglobin is low, then go for the cause of it and go for substitution if iron deficiency is the reason. And we like to be fast, and we like potent drugs. In anesthesiology, we like potent drugs, the most potent analgesic drugs, the most potent hypnotic drugs, and we like intravenous iron. We don't want to wait for weeks until oral iron is working. It takes 4 to 8 weeks. Nobody can stand that. We want it now, we want it fast, we want it intravenously, because there we get a response depending on the bone marrow, but we get a response much faster. And honestly, in our hospital, if we cannot manage it, we still cannot manage it, to get the patients early after the indication from our orthopedic colleagues. And if we get the patients in the hospital and we see the day before surgery that there is a low hemoglobin and there is an iron problem, then we give it there after admission, before surgery. So in order to get a response from the bone marrow, a response in reparation phases, if you will, within a hospital stay. So this is our trick. This was a tricky message now. But there's a review article that explains much better why some of the interventions work and how we should do that. And I recommend this article published last year to you. This is our algorithm, how we do it. We assess blood count, hemoglobin, look if it's hypochromic anemia, and then we look at once at the ferritin level, because this is a marker, an indicator what the most likely cause of anemia is. And if this is low, then it directly goes to iron substitution in the presence of an anesthesiologist. It's quite safe because the occurrence of allergic reactions is not zero, so you have to watch your patients, of course. This is our simplified algorithm, and currently our orthopedic surgeons ask for a blood test which contains, of course, the blood count and ferritin, vitamin B12 and folic acid at once. So we don't do it in an escalating two-step approach, but in all patients we assess these 4 parameters, if you will. So we have at one glance the result and can react immediately. Next thing and next message in all these recommendations, including the ESA guideline, is use cell salvage. I'm sure that in all your ORs you will have cell savers, autologous blood donation machines, and this is really highly recommended, and there's a good evidence base available that you really should take that shed blood, lost blood during surgery in that container, centrifuge it, wash it, and return the washed blood. There's a recommendation, a clear recommendation against the retransfusion of unwashed blood, which was quite popular in orthopedic surgery previously. But it is like a cytokine soup you return if you do not wash it and centrifuge it. So it is important that you really, for blood conservation, take a machine that is able to make all these processes of washing and separating cells. It is important to keep your patient normothermic, and your anesthesiologist has also to take care about acidosis and their prevention and correction. As I mentioned earlier, tranexamic acid is very popular in all, probably the orthopedic colleagues representing their countries here at the Congress. Currently, it is given in various dose regimen at various combinations, intra-articularly, intravenously, as a bolus, as a continuous infusion, post-operatively. The best design has not been established yet, but the important thing is you can stop and prevent hyperfibrinolysis, you can stimulate your platelets, you can do a push to your endothelium, not to yours, to that of your patient. So it is currently no signal there that you can really do a big harm. Still, we think that thromboembolic history or coronary heart disease should be included in our consideration to give it or not prophylactically. Yes, please.
What are the contraindications for tranexamic acid?
Basically nothing. This is why many of our orthopedic surgeons insist.
Because we have always to fight with the anesthesiologists sometimes, because whenever it's a difficult patient, for whatever reason, he says, no, I cannot use tranexamic acid.
Yeah, I agree with your anesthesiologist, because in our history we had aproteinin before we used tranexamic acid or epsilon aminocaproic acid, and aproteinin has been killed. The drug has been mobbed and finally killed because big databases showed that it increases myocardial infarction, various ischemic thrombotic events. And this was the reason, the side effect on the vasculature was the reason why we lost this very potent antifibrinolytic drug. Now, we don't want to be silly again and use it in patients with risk of ischemia, myocardial ischemia, for example, and thrombotic events, because this could, in some big data analysis, finally result in the termination of the use of tranexamic acid again. And the signal is a mini signal, but still, if you increase that risk, you don't want to give it too liberally. So it makes sense. And it makes what we use and we negotiate with our orthopedic surgeons is, look, there's a recent, there was a stent implantation, there was a deep vein thrombosis in previous years of that patient. Let's withdraw a prophylaxis, but probably use it if bleeding is strong, and then rebalance it and then give it. So we negotiate that we don't give it prophylactically, but therapeutically. But basically, it is given and requested quite liberally, and there have been congresses in the orthopedic world showing that there are no signals of these feared side effects on the horizon whatsoever. Future will tell us. Whether wet, not dry, if there is bleeding, we, not you, you have to do your work manually. We have to do our work to resuscitate the patient, to refill what is lost in the cell saver or on the floor. So for volume resuscitation, we need to do something to target the intravascular compartment. And what we learned in recent years is don't give too much. It is not harmless to overflood, to flood our patient. We destroy the endothelial glycocalyx, a very nice, tiny structure where all the exchange of solutes and compounds takes place. So we have to be careful not to result in hypervolemia, and this is why in many of our ORs you will see more and more Doppler monitoring or CNAB for non-invasive pulse pressure variation monitoring or other invasive monitors, Vigileo, for example, in order to assess the fluid status, the filling of the patient, because blood pressure is no parameter for filling and heart rate is not a parameter for filling. So this is recommended to assess preload. And then, of course, stop the bleeding. And you are so important. I mean, if you do spine surgery and many things are open where you cannot really do something to stop bleeding, then we have to do the job with our pharmacological interventions. But in many other areas where you can put sutures in, where you can put your thumb on the bleeding vessel, there you are requested to stop surgical bleeding. We have fibrinogen concentrate available, and it is really recommended in those cases where fibrinogen is low. Why? Because we need it in terms of physiology clot formation. And we have found out in the literature, even though only with C here, that the minimum level at the low normal level is required for a clot to be strong. We have PCC in our armentarium, which is a prothrombin complex concentrate, and this is highly recommended in all those bleeding patients that who were on warfarin, on Marcoma, before surgery or before trauma. Recombinant factor 7A is almost gone out of our orthopedic surgical departments, and it would be off-label to use it. It is a strong push. It is a very strong, unpredictable push for thrombin generation. So in most of our scenarios, even in big scoliosis surgery or severe cases, we will not need it. But what we need is, however, an algorithm, and it is highly recommended to use predefined triggers and targets incorporating viscoelastic hemostatic assays here for our bleeding management. So in our hospital, in the Evangelical Hospital in Vienna, in the 18th district here, if you have time, you can come and visit me. We have a checklist with only 10 items, what to do and how to proceed when bleeding occurs. SOPs are recommended, algorithms are recommended, which is a highly individualized medicine, because you look at what the patient is needing and give interventions appropriately, individually. Avoid allergenic fluids is another message in all these recommendations I mentioned. Plasma transfusion is an allergenic blood product, and we recommend against indiscriminate use. Factor concentrates are preferred because they are virus inactivated, blah, blah, blah. Many, many advantages compared to that soup of plasma. In trauma surgery, it has a place, however, because before you can do damage control, before you can really stop the bleeding process with surgical means, sometimes you have to use a ratio-driven, for example, one-to-one approach. But in elective cases, there is no evidence there. This is only a 2C lowest grade suggestion, and as soon as possible, go to a physiology-based approach. Transfusion target 7 to 9 gram hemoglobin, not higher. This is quite well accepted by anesthesiologists, and the 1A, the best grade recommendation to use a restrictive transfusion strategy has been accepted and internalized by most of my colleagues. What was helpful is to change our traditions and behavior. Previously, we said that 1 RBC is nothing. If you transfuse, then only give 2, because 1 is like, as I said, nothing. To rethink and say transfuse one RBC after the other, measure in between if you need the second one indeed, helped to reduce the consumption of allergenic blood products. Avoiding ratios in elective surgery helped. Avoiding the abuse of 2-FFP, which does not change anything in terms of coagulation factors or in terms of blood tests, helped. And to reduce the amount of blood withdrawal, specifically in intensive care medicine, helped as well. Because if you have renal replacement therapy and these clots, then a lot of fluid is gone, a lot of blood is gone. If you withdraw big samples always, then in a regular daily basis, then you end up in an iatrogenic blood loss. So what was important was to teach our colleagues, not only in the OR area, but afterwards in the post-operative wards, when to transfuse. To transfuse when hemoglobin is higher than 12 is rarely indicated. But to think about transfusion in a hemoglobin level below 6 is quite likely. To consider about compensation modalities in the ECG, looking at lactate levels, this is something what we teach our young colleagues on the ward, on our staff on the ward. Post-operatively, we like to give IV iron as well, and there's some literature popping up now supporting this approach. Specifically after spine surgery, we give IV iron systematically, more or less. This is a proposal of a checklist, a surgical checklist, a POB safety checklist with sign in, team time out, and sign out, as you know it from your regular WHO checklists, but here it is dedicated to PBM. For example, the question of preoperative anemia, excluded or irrelevant, or if identified, corrected or not corrected. And if not corrected and a big orthopedic intervention is planned, then this not corrected here would stop all further surgical interventions. You need the patient on board and the understanding of the patient, and more patients are aware of PBM, and we support that by patient information in a barrier-free language. PBM is easy, POB management is easy, basically. You just have to do it. This would be a case, but since it is so late, I will just jump over it and don't talk about his surgical procedure. It's just re-emphasizing what I mentioned earlier. But what I would like to conclude at this stage is that bleeding management means that physiology needs to be considered, and there are evidence-based medicine guidelines. They are there, they are published, they are free to be accessed. They have the main message that all our patients are individuals and have to be treated individually, and we should apply multimodal strategy from pre-op until discharge. If you want more from PBM, from this information, then we offer a PBM master course produced and guided from the Danube University Krems. And this is the content. A lot of work to do, but in the end you have an MSc degree. Are you interested in thrombosis, or should we go to pain management, which is the second topic?
Pain management.
One voice for pain management, not thrombosis. Let's keep thrombosis. Do you agree? Agree.
Yes.
Okay. Could you please give me the second presentation? The second task I was assigned to was to talk about pain management. And here I have no declarations of potential conflicts of interest. And I will talk about basics, so again physiology and basics in pain medicine, about LIA and RR, about drug interactions, and probably we'll skip that drug interactions and the opioid-free hospital, because this was one of the ideas from my orthopedic colleagues, that they want a hospital, an opioid-free hospital. So probably you don't have this wish in your area. Definition of pain is it's a highly unpleasant physical sensation and discomfort and emotional status caused by actual or potential illness or injury, or is described by terms for pain. And we can divide pain situations according to the acuity, either as a sudden onset acute pain, or after 3 to 6 months as a long-lasting chronic pain. Pain intensity is not always the same. It can be low on a 10-item scaled score of 1 or 2, or it can be very intense, 9 to 10. So visual analog scale, where the patient sets this marker wherever he or she feels that the pain intensity is, or the numeric rating scale, how strong is your pain from 1 to 10, is the only marker we have to assess pain intensity in clinical practice. In study settings, trial settings, of course we can do something different. We can assess qualitative sensoric testing, assays and things like that. But the problem is that pain is a subjective, emotional, sensational issue, and you cannot really measure it. In our hospital, Evangelical Hospital, you can see here, we have set up something what was very helpful and I would recommend to you, which is a quality circle of acute pain management, where the orthopedic surgeon, the boss there, surgical boss, and down to our nurses were involved, and the ethical group and psychotherapy was involved, and the pharmacy, all were there and formed this quality circle, and we assessed something that should guide us in acute pain management. And for example, we designed there and defined how often should pain intensity be assessed in our patient, and what should we do if this on a 10-item scale exceeds the number of 3 in the resting patient or upon mobilization. What is the algorithm to be followed by all the stuff if these numbers are met? And previously we had to write that down manually in the chart of the patient, but now we have a chart that automatically includes the pain's intensity as the fifth vital sign, if you will. Pathophysiology of pain means that either some receptors are triggered here and transfer their signal via the spinal cord to the cortex, where finally, after signal transduction, the sensation and emotions are considered by the victim. Or the pain is generated somewhere here in the neuralgic, neuropathic areas here. So this means that there are important questions to be asked to the patient about pain quality, because this allows us to differentiate between the receptor-mediated pain and the neuropathic pain. It is important to differentiate it because our therapy is different. It's the main division of our prescription and our pain therapy. Pressure, heat, inflammation may trigger receptor-mediated pain, which is felt like a knife, which is felt like a dwelling sensation, where neuropathic pain, such as one triggered by hepatic effusions or discus prolapse, is rather felt like burning pain or like a electrical current pain, immediately onset and immediate release again. So it is important to ask the patient, how does this pain feel like? And then, of course, for all our interventions, it's important to assess pain mechanisms, or to have at least a differential diagnosis. Is it a physical factor, discus prolapse? Should I do a spinal surgery to release that compression and to do laminectomy or anything like that? Is this a physical factor that needs to be corrected? Or is it a functional factor? Physical factor gets a red flag, and this needs to be, if possible, corrected. Other things will not require orthopedic interventions, which are only pain maintenance factor, aggravation. Psychological factors can be an issue, get the yellow flag, and social factors, back to work issues, or I don't know now the word, pension, was it? Retirement, or the wish for retirement, may be a factor that aggravates pain and prevents the patient to feel improvements from all our pain medicine interventions. Pain visit has two essential things, which is a structured interview and a structured physical examination. Then eventually we need radiological, neurological additional tests in order to end up with a diagnosis. We can also tell our patients, of course, and then a diagnosis-directed therapy. In the acute pain management in our hospital, patient information about the acute pain management is done before surgery. So again, this is a screenshot from the information our patients get and can get from our internet as well. They learn that we will ask about visual analog scale, numeric rating scale before they enter surgery, and they learn that they eventually will get a patient-controlled analgesia device where they have to push a button. It is important to give that information up front so that they then can use it. It is a quality parameter to have a pain-free hospital, but honestly, pain-free is not possible. Painless hospital, but painless is another stupid word. So I used pain-controlled hospital. In German it's easier, we say schmerzarmes Krankenhaus, which means we do all our efforts, we focus all our efforts to the goal to reduce pain. But we are not so idiotic that we think that pain can be avoided in a hospital with surgical departments at all. There will always be pain at a certain level, but we don't want to have excessive pain. This is good for our patients' comfort and, of course, for our collaborators' satisfaction. Goal is pain reductions without complications, lowest effective dose, prescription at fixed dose is important. So also after orthopedic, minor or major orthopedic interventions, we prescribe routinely according to 3 groups of minor surgery, middle surgery, moderate surgery, and high pain-inducing surgery. We prescribe at fixed dose analgesic drugs, and on top, if the numeric rating scale goes beyond 3, then we prescribe a rescue medication for controlling this kind of breakthrough pain. And this is important that the patient and the nurses and all the staff knows, because then we can really be good. And this is one of our main factors that drives the patients to our private hospital. Consider early warning signs of side effects, because all these drugs we use and interventions we use, except for cold and warm application, if you will, but all these drugs have potential side effects and may induce complications. So early warning signs need to be considered carefully. If you go for pain therapy, it means combination, fixed doses, rescue medication, basic drugs, opioids. And combinations means not only drugs, but also our needles, our blocks, and we are fans of blocks. We like to activate patients, because an active patient cannot be think about pain so much, but is rather involved in thinking of getting rehabilitation, getting fit again. Mobilization is a main driver in our pain management concept. Massage, passive things, but active things are even more important. TENS, electrical current things, talking to the patients, and psychological aspects need to be combined. Painkillers have an escalating scheme of route of administration with subcutaneous per oral administration on the bottom, sublingual administration. Down there is a booth from, I can see it now, but if you go down to the area here, you will see a booth where they have the sublingual from Grünenthal, an instrument where you can give fentanyl, ECDS, Salviso, transcutaneous, another thing, going up to subcutaneous administration, intravenous administration, up to intra-articular administration or intrathecal administration of painkillers. We are fans of the OnQ pain buster, and we believe that replacing our femoral and sciatic blocks with all the catheters, which were difficult to carry with the 2 bags for our patients, we think that one of the recipes for improvement and evolution was to use this pain buster here, specifically in knee arthroplasty. Sublingual, as I mentioned, and intrathecal implantation is another route of administration. The WHO didn't only tell us about patient blood management, that we should do it in all the member states, but also implement it for oncological patients, for tumor pain therapy, a 3-stepwise escalating scheme of drug classes. Basic analgesic drugs alone represent WHO step 1. In step 2, basic drugs are combined with weak opioids like tramadol. There's also one booth here with a combined preparation, which is here in that step 2. And step 3, basic drugs and the strong opioid, such as hydromorphone, what we use in our hospital. Pain control at the push of a button is something that is rapidly available, is easy to understand for the patient, but unfortunately takes some efforts in terms of our time and equipment, and these newer versions here are quite costly. So you have to really reconsider if this is better compared to per-oral intake of, as I said, hydromorphone, for example. We don't only have the WHO escalating step 3 concept, we have co-analgesic drugs. which are antineuropathic drugs. And in most of your post-operative pain situations after knee arthroplasty, some aspects and some components of neuropathic pain are there. I've been told by your colleagues that this is up to 20% of patients after surgery. So this is a quite astonishing number. And to combine it a little bit with co-analgesic drugs, like Saroten or Lyrica, would make sense, at least in the early phase, in order to probably prevent memory of pain. Physiotherapy, stimulated therapy, acupuncture, and TENS can be combined. Non-pharmacological means are also there, such as TENS or spinal cord stimulation. Not for the acute pain management after orthopedic surgery, but of course in the population of chronic pain. What is important is that we inform our patients that self-medication is dangerous. There are so many non-steroidal anti-inflammatory drugs given over the counter or given, bought in regular stores, and they finally are taken too long in many, many patients at too high doses, and they really lead to renal insufficiency, lead to gastrointestinal problems, and this is not a trivial problem. So we have to inform our patients that the chronic intake of NSAIDs is to be avoided. This does not work. We had a camera team in our hospital because we have had a new chronic pain management ward, and the question was, is in-hospital treatment for chronic pain patients better than outpatient care? We believe that both is important. First, you do your job with all the differential diagnosis and early titration phase in the hospital with a closed eye on the patient, side effects, and then keep the leash longer, and finally get revisits and consultations at a longer interval on an outpatient basis. So this is our concept. But the film does not work here, so, and it is that we are running out of time anyhow. We have many people here in Austria who really dedicate their life to pain management, and we have a Schmerz platform, which is a group like a task force here in Austria from all people who are working in this field somehow, and the message of this Schmerz platform is a political one, because we do not really get refund or payments for chronic pain patients. So we had to do a lot for the political and insurance side here on this field. In the field of chronic pain management, there is a problem that pain reduction can hardly be achieved without any complications or any side effects, but it is definitely our goal and our requirement, our task to relieve it and to make it easier, to increase quality of life and patient satisfaction, and to improve rehabilitation. Back to work is an important marker for a good chronic pain therapy and, of course, reduction in costs. I don't want to talk about chronic pain management in more detail because I think it is not in your focus. Your focus, I think, is acute pain management, what I strike more. And LIA, local infiltration of analgesic drugs and rapid recovery, is something which is in your, hopefully, field of area. So I want to tell you that we implemented systematically the LIA concept in our hospital. This is the information that all colleagues that enter the OR see when they undress or redress to enter the OR. So every day they get their eye on some ideas, and when we established the LIA concept, they had to read that over and over again. So this is an intra-hospital information, and they had to see while redressing what to do in, for example, knee arthroplasty, how much of ropivacaine they should give before cementation into the dorsal capsule. They must not forget that they have to give it before the cementation. there how much about roughly in which other structures they should give how much and what they should do before skin closures. And why did we do that? And alert our colleagues to do it, because we in the post-operative ward experienced that patients with a good LIA are much better. We did not have to do rescue blocks or give so much opioids resulting in side effects. So we really saw with our eyes that this is a good thing. Are you applying LIA routinely? No. Do it. This is really good. Cool.
Can you repeat the
Which
dosage?
chemical?
Ropivacaine. We dissolve it to 0.375. So it is 1-to-1 mixed by the nurse on the table, the sterile, in the sterile area.
On its own, or because there was also, I know that in Belgium they put also adrenaline and they...
Yeah, there are many recipes. We decided in our first step to use only local anesthetic. We don't want adrenaline because we don't want vasoconstriction there. We want a good surgical repair, wound healing, blah, blah, blah. We don't want vasoconstriction, so no epinephrine. And these pain buster things, they are elastomer pumps, and they infuse it into the joint for 48 hours. So there is diffusion there, but it is obviously it is fine enough without adrenaline, because we had internal audits over and over again, and we really see that it works fine. We tried to add NSAIDs, because there are receptors in this area here, and we tried to add cortisone, which is in some recipes also involved, but we are afraid, our colleagues, the orthopedic surgeons, were afraid of any infections. We didn't see any, but because of that fear and the gain in pain reduction, the low gain in further pain reduction, we decided not to add anything. So it's plain local anesthetic. What we did early on was to combine our blocks, femoral blocks, with the pain buster, the intra-articular continuous local anesthetic infusion. And we thought, it could be dangerous because we infuse it over days and there could be toxicity. And of course, all the team members were informed what early warning signs were, and we looked very carefully that we did not infuse too much via neuraxial blockades or peripheral blocks. For example, in shoulder surgery, not to do intra-articular and scalenus block continuous infusions in order not to exceed daily recommended doses. And once we measured ropivacaine levels, this was many years ago, and we have had such a low numbers of participants so that we were not able to publish it. It is only published as an abstract, but not as a paper, because we would have had to add much more patients, and in a private hospital this is quite tricky to run a clinical trial, even though I would have liked to do it. We measured it in the wound drain, in the cell salvage system and intravenously, and found finally that the levels in the retransfused blood is so low that it is not dangerous to use the cell salvage system simultaneously while having an intra-articular ropivacaine infusion installed. What is also important is rapid recovery, early mobilization in the recovery room, and you can only do this and walk around one round. Our patients have to do one round 2 hours after surgery. If they have a good anesthesia, otherwise it is not possible. And if you do not have a dedicated team with a commitment to rapid recovery, it also does not work. Our team gets intra-hospital information about drugs, side effects, mechanisms of action, about costs, so they have a feeling, hey, we are saving €67 per case. I don't want to talk about drug interactions in detail because it's 10 minutes to 1. I just want to give you one key message. My recommendation is to use an IT drug interactions, DDI, drug interactions program, highlighting eventual drug-drug interactions. We learned a lot from that. And this is my message to you. Further comments? I don't know what you have to do now, if there's lunch or the next lecture, I'm not sure. Next lecture?
In 20 minutes.
20 minutes, so use your 20 minutes of time. Was habe ich noch?
There is no last round.
No.
According to this one.
No. According, we did the test with the last presentation. 20 minutes, so we have some coffee break.
In 20? When it's written lunch?
10 past 1. And
There is a lunchtime in the program. After the same minutes, we have lunchtime and then
after 2 o'clock.
Yes.